So the first chapter for revision would be your cell injury. In the main exam, you can expect 1 to 3 questions. Now, the topics which came in this chapter the last time were apoptosis, calcification, and the irreversible injury. So in this chapter, the most common cause of cell death is going to be hypoxia. And there are multiple forms of hypoxia. The most common cause of hypoxia is ischemia. In this chapter, we'll be talking about the outcomes where when a cell injury occurs, how the cell comes out of it. I mean, first thing would always be adaptation, then the reversible, irreversible, intracellular accumulations, and cellular aging. Talking about the adaptations, there are 4 types: hypertrophy, hyperplasia, metaplasia, and atrophy. For hypertrophy, if we talk about, it is always increase in the size of the cell. There is no difference in the number of cell. Increase in number of the cell is called as hyperplasia. Hypertrophy is more physiological, whereas hyperplasias, they are more pathological. Any cell which has to undergo hyperplasia, increase in number of cells, should have the ability to replicate. Otherwise, it won't show hyperplasia. The nuclear content in hypertrophy itself, it increases because the cell size increases. It is more physiological type of a cell even after having hypertrophy. So any normal cell will maintain the NC ratio, that is 1 is to 3. So if the cytoplasm is increasing, the nuclear content also increase, whereas there is no change in the hyperplasia. Reason for hypertrophy is increase in the workload, and mechanism is increase in the structural protein, whereas reason for hyperplasia is increase in the growth hormones or growth factors. And these growth hormones and growth factors, they will increase the speed of division. When we talk about the examples, now we have discussed multiple times, we revised multiple times in the class that uterus during pregnancy will show both hypertrophy and hyperplasia, but better answer would be hypertrophy. Whereas breast during puberty and pregnancy, it shows both, but the better answer will be hyperplasia. And during lactation, the only answer we'll have is hyperplasia. Cardiac muscles, because they are permanent cells, they do not have the ability to replicate, so they can't do hyperplasia. In heart, any kind of stimulus, any kind of damage will always and always cause hypertrophy. And for endometrium, it will be endometrial hyperplasia. Now, in the endometrial hyperplasia, there can be 2 types, simple and complex. And the complex endometrial hyperplasia, where the shape of the glands are also, changing, this is a risk factor for developing of endometrial carcinoma. Metaplasia, change in one normal type to another normal type. The reason is stem cell reprogramming. There are 2 types of metaplasia we had discussed: epithelial and mesenchymal, the brick and the cement. Now, in the cement, mesenchymal, we have these 4 examples: bone, cartilage, muscle, and vessels. And one of the metaplasias which are seen with mesenchymal tissue is muscle converting into bone, that is myositis ossificans. In the epithelial one, this is the most common metaplasia overall because epithelial contains 2 metaplasias, squamous and columnar. And squamous metaplasia is the most common metaplasia overall. Now, whenever any cell changes to squamous cell, you call it as squamous metaplasia. So the name of the metaplasia is dependent upon the final type of a cell you are getting. So squamous metaplasia means any normal cell converting into squamous cell. Columnar metaplasia means any normal cell converting into columnar cell. There is examples of squamous metaplasia like a respiratory epithelium where normally you have columnar cells, but because of smoking, it converts into epithelial cell. Likewise, gallstones lead to the GI epithelium changing into squamous. For a columnar metaplasia, the example is Barrett's esophagus. The hallmark of Barrett's, we all know, is goblet cell. They produce mucin, so the stain is Alcian blue or mucicarmine. The location of the goblet cells is multiple places in the body, but the majority are there in the intestine. That is why now you are seeing goblet cell in the esophagus, so you call it as intestinal metaplasia too. Barrett's esophagus is a pre-malignant condition and it gives the chances of developing of adenocarcinoma esophagus. Atrophy, decrease in the size or the number of the cell. It can be both together or can both be separate. The atrophy is always accompanied by autophagy because of UPP pathway, ubiquitin proteasome pathway, and the marker of this atrophy or autophagy is LC3, that is light chain 3. In a reversible injury, the ion responsible is sodium. The first overall change is mitochondrial swelling. The first morphological change, जो आपको दिखेगा, that change is cellular swelling. Other changes could be fatty change, leading to fat droplet deposits inside the cell, cytoplasmic blebs, where the outpouching of the cell membrane is seen. Then you have your organelle damage inside, but all reversible. Then there would be chromatin changes, chromatin condensation, and there will be presence of these myelin figures. So these myelin figures, they're the breakdown products of the phospholipid membranes. So these are the changes which you see in reversible injury. In a irreversible injury, it is calcium which is responsible. And more calcium, it goes inside the mitochondria and cause deposition of it inside the mitochondria, leading to formation of amorphous flocculent densities. This was the question which was asked in a recent exam. Why calcium can cause cell death and why sodium cannot cause the cell death? Sodium is an ion for reversible injury. Calcium is an ion of irreversible injury. So why calcium can cause cell death? Because it can activate enzymes. The name of the enzymes is APE, ATPase, protease, phospholipase, and endonuclease. ATPase will cut the ATPs, protease, phospholipase will damage the plasma membrane, and endonuclease or DNAs will damage the nucleus. So damage of the phospholipid membrane will show the presence of a very high number of myelin figures. Myelin figures can be seen in reversible, irreversible, both. So you can see that myelin figures can be seen both ways, reversible and irreversible. Therefore, they are not the hallmark feature of cell death. The hallmark feature of cell death is always going to be amorphous flocculent densities. In the endonuclease DNAs, it can go and cause the damage of the DNA. And there are three things which can damage the DNA, three ways by which the DNA can be damaged. One, it can condense, pycnosis. One, it can break down into multiple pieces, karyorrhexis. And one, it can be lysed completely, karyolysis. There are multiple examples of irreversible cell injury like necrosis, apoptosis, pyroptosis, necroptosis, and ferroptosis. Let's see them one by one. When we talk about the differences between necrosis and apoptosis, I hope all of you know for a necrosis, we talked about a blast, and for apoptosis, we talked about a 100-year-old person dying. Why 100-year-old? We took that the physiological lifespan of a person till 100 years, and after that, the person is dying. So, necrosis, it's always pathological because the death is happening due to a blast, whereas apoptosis, it's always and always more physiological in comparison to pathological. So, in necrosis, there will always be a group of cells. In apoptosis, it can be a single cell dying or multiple cells dying. In necrosis, the cell size, the overall area which it will take after a blast will be more. And in apoptosis, because it's 100-year-old, so it shrinks because there is formation of apoptotic bodies, small bodies. Now, the cell membrane in necrosis will be damaged because after a blast, nothing will be seen, but apoptosis, it will be intact. Inflammation, where the WBCs comes at the site and fight, so it will be always seen in a blast site. So necrosis contains inflammation, apoptosis does not have inflammation, and for a nuclear changes. That's the hallmark feature of these cell deaths. In necrosis, you'll not find anything karyolysis, and in apoptosis, because everything is compressing, so it will cause pycnosis. Okay, and this we had discussed before also that in necrosis you are seeing the tombstone appearance. You are not finding anything in necrosis. The pink color paintbrush where this all cellular debris is seen. Okay, and in the apoptosis, there will be formation of bodies, the apoptotic bodies. And these apoptotic bodies, they are such that the question which came in your exam was that what does the apoptotic body has? So they contain all the cellular content plus minus the nucleus. So nucleus could be seen, the nuclear content, or it might not be seen. And once you have a formation of apoptotic bodies, it give you a signal, eat me signal. And this eat me signal is going to be given to the macrophage, and macrophage will come and eat this apoptotic body as seen here. This process is called as phagocytosis, or here we are calling it as efferocytosis. Okay, we have discussed this too. Now, this necrosis, how many types? Necrosis is of five types. The most common type of necrosis is coagulative necrosis, seen in all solid organs except brain, pancreas, and dry gangrene is an example of coagulative necrosis. Okay, and it is due to protein denaturation. Liquefactive necrosis, it is due to enzymatic digestion and it is ischemia to the brain, abscess in pancreas. And wet gangrene is an example of liquefactive necrosis. And please remember this that liquefactive necrosis is also called as colliquative necrosis. Okay, then the caseous necrosis, it is seen in TB. For a fat necrosis, we know the process of saponification will be seen. It is seen in fat tissue like pancreas or any adipose tissue, and it will have chalky white deposits in it. So chalky white deposits, these chalky white deposits will be seen. And then we have fibrinoid necrosis, which is deposition of fibrin with the dead cells, and fibrin is a coagulation factor, activated factor number one. So it will always be found with the vascular injuries, the vasculitis, malignant hypertension, all these can cause fibrinoid necrosis. So five types: coagulative, liquefactive, caseous, fat, and fibrinoid. Okay. Then if we talk about apoptosis, it's a programmed cell death, two phases. the initiation and execution. Initiation is have intrinsic and extrinsic pathways. The intrinsic pathway is also called as mitochondrial pathway, where the mitochondria is going to be leaking out the cytochrome C. So what we discussed in the classes that every cell has got sensors. These sensors will sense the stress, will tell the mitochondria that what to be done. If the stress is too much, they will tell the mitochondria it's time, and mitochondria will activate a pro-apoptotic molecule which will allow the leakage of cytochrome C from the mitochondria into the cytoplasm. Once the cytochrome C comes in the cytoplasm, it binds with the calcium, and after making complex with the calcium, it is called as APAF. And this APAF will activate a caspase. Which caspase for the intrinsic pathway? 9. We discussed already that what is the purpose of every step of apoptosis. The purpose of every step of apoptosis is to activate the caspase. In our body, we have pro-caspases, the inactive caspase. And now we are converting into active caspase. And what is the intrinsic caspase, Chodo? Caspase 9. The molecules which are anti-apoptotic, they're going to have long life, and because long life contains L, so any molecule having L at the end, it is anti-apoptotic like BCl, MCl, BClXL. But this BClXS, now this is having S at the end, short life, so it is not anti-apoptotic, it will be pro. So BClXS is a pro. In a pro-apoptotic molecule, because it's going to cause apoptosis, A for apoptosis, so any molecule having A in the center is pro, backs. And then this bad, it is bad because it contains A in the center, but never behaves like pro-apoptotic molecule. It behaves like a sensor. And for a sensor, it's Puma, Noxa, Bim, Bidbat. These are the sensors. For an extrinsic pathway, death receptor pathway, where the death signal is going to come from the body and going to cause the cell death of the cell. So the death receptors, the most common death receptor, yaad rakhna choto, usko TNF receptor. But the receptor which is we are talking about here is fast receptor. It is the molecular marker. Please highlight this point. Molecular marker of apoptosis is fast, CD95. When it binds with its ligand, the fast ligand, it's going to give you a formation of a complex FAD. And this FAD complex is going to activate the caspase 8. The moment you activate the caspase, step is complete. So what is the intrinsic caspase we read earlier? 9. Extrinsic caspase 8. Now, whichever pathway the body has chosen, body has initiated the apoptosis. Now, once you have initiated, you execute it. And for the execution, you have activation of caspase 3, 6, and 7. All right. Now, once you have done it, after that, the eat me signals are going to go on and apoptosis is going to occur. So caspases, they are the enzymes which are made up of cysteine, and they are going to cut the chain after every aspartic acid. Now, there are initiator caspases, there are executioner caspases. Initiator caspases could be intrinsic, extrinsic, 9 and 8, and executioner 3, 6, and 7. Out of them, the most important one is 3. The 3 is the most important caspase of all. Now, the marker of apoptosis is an XN5. Again, this question came in your exam this time. That what is the signal which actually causes the initiation of apoptosis, and that was PS flipping. So every cell on the inner membrane has got a PS receptor, but once it undergoes apoptosis, the PS receptor from the inner membrane comes out. And when it comes out, if you put an XN5, this PS receptor will be stained. And this PS receptor is the flipping of the PS receptor is the signal for eat me, for a macrophage. So they ask you that what initiates, so PS flipping. The stain for apoptosis is tunnel, and the inhibitor of apoptosis is flip. Flip and flipping दोनों अलग अलग है ठीक है flipping is the initiator flip protein slice like inhibitory protein is the inhibitor of apoptosis. Then on DNA agar-gel electrophoresis, no finding, it is nothing, normal cell. If it is smearing, entire DNA structure is damaged, then it is called as necrosis, and step ladder pattern, it will be apoptosis. Necroptosis, when both of them are going together, as I told you, just learn the names. Program necrosis, caspase independent cell death, and it is seen with which viral infection? CMV. Why necroptosis is causing a cell death here? That the pro-caspase 8 is not able to convert into caspase 8. And when you are not able to convert pro-caspase into caspase, you need to kill the cell by some way. So what are the other ways of killing it? With the help of free radicals or maybe WBCs. So when the cell death starts, as apoptosis, finishes as necrosis, together is called as necroptosis. In a pyroptosis, we know that there will be caspases 1 and 11 activation plus interleukin 1. Interleukin 1 is the interleukin for fever, and caspase 1 and 11 will cause apoptosis, and together they will be called as pyroptosis. Ferroptosis, this we also know, more iron, more free radical. And once the free radical is there, free radical, they are single, ready to mingle. They're going to damage the cell from they will damage everything. They will damage the phospholipid membranes and all. The question which can come is that what is the organelle which is going to damage in ferroptosis first? That is your mitochondria. And which part of the mitochondria? So to please remember, inner layer of the mitochondria is the first thing to damage in ferroptosis. Then we comes to the last part, that is intracellular accumulation. This intracellular accumulation, Chodu, you have glycogen, protein, and fat. Glycogen and protein, they're PAS positive, fat, Sudan, and oil redo positive. Pigments, lipofuscin, other name is lipochrome, wear and tear, senile aging, and I hope you remember it's a perinuclear pigment only seen around the nucleus, golden brown in color, and why it is being produced because the lipids are being damaged by the free radicals and it causes brown atrophy of the heart. The most common organ where you see the deposition of this lipofuscin pigment is heart. So therefore, brown atrophy of the heart. Whereas hemosiderin, this is hemoglobin derived, hemoglobin dark in color if too much of hemoglobin is there. So dark red brownish in color. Why it can happen? Due to hemolytic anemia or repeated blood transfusions. The stain, because we are talking about hemoglobin, hemoglobin contains iron, which form of the iron? Fe2 plus. But because it is getting deposited, so iron, when it has to deposit, it converts into ferric form, and therefore the stain is Persian blue and pearl stain. The stain for ferrous form of the iron, I told you, is lily stain. Then comes your melanin, black in color, meson fontana, tanning with melanin, tanning with melanin. Collagen, meson trichrome, stain. Then comes your calcium, the most important topic. Straightforward questions are going to come. And these straightforward questions of this would be pathological calcifications of two types, dystrophic and metastatic. Dystrophic calcification, D for D, dead, dying disease tissues. And metastatic calcification is seen in a normal cell. The serum calcium levels in a dystrophic calcification will be normal because the cell is dead, so the pump is not working. Even a normal calcium entering inside the cell will cause calcification. For a metastatic calcification, the cell is normal. So in a normal cell, hypercalcemia can only cause calcification. What are the reasons for hypercalcemia? Like multiple myeloma, vitamin D related diseases, hyperparathyroidism, chronic kidney disease, or milk alkali syndrome. Whereas for dystrophic calcification, the mnemonic I gave you was ART, atherosclerosis, rheumatoid nodule, and tumors. For a tumor, what do you see in a biopsy? This is samoma body. And what is the mnemonic of the samoma body? PSM. The papillary tumors, the serous tumors, meningioma, and mesothelioma. बेटा इस पे इतनी बार क्वेश्चन आया ना कि आप when you solve the PYQs, Chotu, you will find this question multiple times this way or that way, and specifically on this meningioma thing. ठीक है, some more bodies with meningioma. So please learn this topic. I hope you remember from the classes. I hope this quick revision has helped you. Some more bodies, they're concentric laminated deposits of calcium. Now cellular aging, telomere, the end part, with every division, it loses the length, and when it's non-existent, cell stops dividing. That is called as cellular aging. But telomerase enzyme, it maintains the telomere length. It's a misnomer, छोटू ध्यान रखना. It's a misnomer. काटेगा नहीं. एज का मतलब क्या होता है? काटना. But it's not going to cut. It's going to maintain the telomere length, and the cell will go into infinite division. What is the mnemonic for this? GST: germ cell, stem cell, tumor cell. Delayed cellular aging can be done by cell calorie restriction. तो थोड़ा कम खाओ, अभी टाइम है, पूरे दिन बैठे हो, पढ़ रहे हो, बैठ के ब्लू ब्लू खाते रहना है, मोटे हो जाओगे. So calorie restriction and sirtuins. It is present in red wine. It decreases the apoptosis, it decreases the cell division. So obviously you are expanding the cell life. And the last topic in this chapter, free radicals, they are reactive oxygen species. They're also called as oxidant, and they are having unpaired electron in the outermost orbit. We have to learn just one word: single, ready to mingle. There are multiple examples of it. I said hydroxyl, the most common one, peroxynitrite, hypochlorite, the most bactericidal, then H2O2, hydrogen peroxide, and superoxide ion. Then formation is Hebowese and Fenton reaction. Hebowese, you're forming H2O2. In Fenton reaction, you're using iron, you're using hydrogen peroxide, and you are making hydroxyl ion. Removal of free radical, the antioxidants, vitamin C is the most vitamin E is the most potent antioxidant vitamin. There are enzymes which we have discussed. There are four enzymes: catalase, peroxidase, glutathione peroxidase, and superoxide dismutase. But a catalase, peroxidase, and glutathione peroxidase, they are doing what? They are breaking your H2O2 into water and oxygen. And superoxide dismutase, it will require two steps to break superoxide ion. First, there will be SOD, which will be converting your superoxide ion into H2O2. And then to break this H2O2, you require any of these: catalase peroxidase and glutathione peroxidase. Okay, Chotu? Now, SOD1 and 2, there are two types of SOD, no need to learn. And this enzyme, you have to learn that there is an NADPH oxidase or phagocytic oxidase. This enzyme can lead to the formation of free radicals. Okay, so this is how, quickly we have gone through the entire chapter. And I hope that if you listen to this, it will just give you the feeling that, okay, yeah, I remember him, what he said. And now when you read your topic yourself, just sit with your chapter yourself, it will help you in quickly regaining things and move on. Thank you very much for watching this. See you in the next. Bye bye.